Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about a biologic agent which is being used in the management of non-infectious uveitis in ophthalmology, that is mycophenolate mofetil. Today we will discuss its mechanism of action, about its uses and its possible side effects. Well, if we talk about the history of this medicine, it was first time discovered by a physician. His name was Bartolomeo Gezio in 1896 from a fungus, and he found out its microbiological, microbacterial activities, and it was from this fungus, and it was from the Penicillium brevicompactum. That was the microorganism from which, for fungus, which it was discovered first time. And later on in 1912, there were two more scientists who worked on it. Their names were Ashberg and Black, who further discovered their antimicrobial activities. And up till that time, it was named mycophenolic acid. Later on, two physicians, Dr. Elson and Eugene, they ultimately discovered its role in immunosuppression and the development of the final product, that was mycophenolate mofetil. Well, basically, if we talk about the mechanism of action of the mycophenolate mofetil, it acts on an enzyme, that is inosine monophosphate dehydrogenase. And when it acts over there, it acts on this enzyme, so there is a depletion of the guanosine nucleotides, which are essential for purine synthesis. When there is no guanosine nucleotides, there is depletion of B and T lymphocytes. So basically, ultimately, this medicine causes depletion of B cells and T cells, lymphocytes, and ultimately it decreases the immune response of the body against different diseases. We talk about its way of action. It actually inhibits the proliferation of B and T lymphocytes by non-competitive reversible inhibition of inosine monophosphate dehydrogenase. And that's non-competitive and reversible inhibition ultimately leads and affects the production of guanine nucleotides. So this is basic description about its mechanism of action. Basically discuss its pharmacokinetics. Its absorption time in adults goes up from 0.63 to 1.8 hours, while in children it can go up to 3 hours. Its distribution basically is by binding to the albumin proteins, that is 97%. And if we talk about its metabolism, it is rapidly and extensively metabolized in the liver by esterases. Its active component, as I mentioned, is mycophenolic acid, and it's excreted mostly by the kidneys, by renal mechanism, 93%. And along with that, fecal and bile, also its excretion is. And if we talk about its half-life, that is 17.9 hours. So this is basic and brief description about the pharmacokinetics of this medicine. Basically, this medicine was initially used in liver, kidneys, and liver transplants as an immunosuppressant, but it was found very effective in ocular immunology, and now it is quite frequently used. Its dosage can range from 1 to 1.5 grams 12 hourly, and along with the oral steroids. So it is very effective in controlling different ocular inflammatory conditions, non-infectious. As its side effects are concerned, the adverse effects, it is usually not very good and contraindicated in pregnancy because of its teratogenic effects. It may cause cleft lips, palate, and distal limb abnormalities, congenital malformations. So it is contraindicated in pregnancy, and it has a tendency to cause post-transplant lymphoproliferative disorders over there also, blood dyscrasia. So these patients, we routinely do regularly the CBC blood counts regularly. Along with that, the patients may have GI bleeding, and these medicines, when we are giving, we should avoid the use of live attenuated vaccine for the influenza, for COVID, and because there is sometimes reactivation of the viruses, hepatitis B, C. So these are the possible complications. Whenever we are using, we keep an eye on the blood works, liver function test, blood works, renal profile, all these things to be kept in mind. The role of discussing this medicine is that it is a biologic which affects B and T lymphocytes, and it is a steroid sparing agent. When we find a patient with non-infectious uveitis, we usually treat with high doses of the steroids to control the acute inflammation over there. In non-infectious cases, I'm talking about, and we can give for 3 days to up to 5 days IV steroids, high doses, and once after that oral steroids are given, and then these steroids are tapered off. Meanwhile, we also start along with this mycophenolate mofetil, because its effect starts developing after 8 weeks. So while on the one hand we are decreasing gradually the steroids after getting good control, meanwhile after 8 weeks this mycophenolate also starts working. So this is the role of steroid sparing. The reason is that steroids can cause cushinite effect, they can cause adrenal suppression. If used above the physiological dose, that is 5 to 10 milligram above, if we use for long term, then all these side effects of steroids happen. For example, cataract, glaucoma, bone osteoporosis, so many things which happen. And then we have to use vitamin D supplements and all these things to manage the bone density changes, and vitamin D to control the side effects of the steroids. So its basic role is to steroid sparing agent. I mentioned it can be used along with the steroids on the low doses steroids. It can be used for long term, although a little bit expensive this medicine is. It is a safe monotherapy, and it can be used in those patients who are steroid dependents and who need the steroids for long time, long course, and in resistance uveitis cases it is very effective and it is giving very good results. Basically, when I talk about the non-infectious uveitis patients, I talk about the Behçet's disease and VKH patients, serpiginous choroiditis, birdshot retinochoroidopathy, multifocal choroiditis with pan-uveitis, and even in anterior uveitis patients which are not getting controlled and steroid resistant, even there it can be used. So it is a very effective treatment for the control of different non-infectious uveitis patients. If we talk about children's like juvenile idiopathic arthritis, our choice goes towards methotrexate, that is more effective. And if we talk about pregnancy, in pregnancy we can go for the steroids and cyclosporine. Yes, as I mentioned earlier, because of its teratogenic effects, this medicine should be avoided in the pregnant patients. So this was the brief description about its history, how it was discovered, its pharmacokinetics, its mode of action, how it acts on the B and T lymphocytes, and basically affecting that enzymes and controlling it. And it is very effective treatment for the patients who need this immunosuppression therapy for the long run. Because of the use of this medicine, we are minimal dependent on the, especially talking about the adults, on the steroids. And now those side effects which were great problem for us to manage and handle over there, have substantially has been decreased those effects over there. So I hope this brief description, its mechanism of action and its use I hope it will be beneficial for my respected audience in their clinical practice. It can be used effectively to control the resistant cases of uveitis, and where our target is to avoid the side effects of the steroids, because if we have to use it above 5 and 10 milligram dose, which is physiological dose, and for long term, then we will have those problems. So it is very good, and I hope this presentation will be beneficial for my respected audience as far as the brief description and history and mechanism of the mycophenolate mofetil is concerned. I want to thank you for your attendance and presence.